Hello, hello, hello. Well, if we have a short turnout, this may be a short review session. With a small turnout. Sorry? Just you so far, yeah. Well, if it's just you, I might pull up a chair and sit back there with you and try to let the wireless do this. Some people wanted me to Zoom, so I Zoomed. So, but they have 3 more minutes. So, you guys practicing inside now since the weather's lousy?
We tarped it at 12:30, and then we just the dealers took ground balls on it because it was dry. I'll hit this swamp. I mean, we're on target again.
Yeah, they redid the outfield drainage and it's still not very good. I think, this is my guess, I think the drain, so the drain starts at the track. I think the drain goes uphill. I think that's why the drain is no good. Because it goes downhill from there into the creek.
We have to like pull the tire cart that way against the fence, try to drag it around that field.
Yeah.
It's worked out so
Yeah. When they redid that track, they put a lot of money into redoing those drains. In fact, the original design and building of the track, the drains are in the wrong place. And the person who was the business office guy at the time, he had them dig it up and redo it. When you agree to certain plans and they're not to plans, you can tell them, here's the plans, this is not what's to plans, redo it. Otherwise, you can sue them or you can have them, come back and redo it at their expense. And that's what your contract is for. And they had this guy come out with this really cool machine. It's a robot. He snaked it down and then the robot walked through the drains, and the drains are clogged, of course, they were terrible. So they dug all that up and they relayed it. And then I don't think, because they did not dig up the baseball field, I think they just connected them with the drains to the baseball field. And my guess, because if you walk the parking lot to the baseball field, that is slightly uphill, ever so slightly. Then when you get to the field and you walk, say, to center field, you've definitely increased in elevation. And water does not run uphill. Hey, Caitlin. So we have 2 people on Zoom. 2 people on Zoom, 2 people here. Well, we've got some people who are not feeling terribly well. There's something going around. Well, the whole volleyball team, I think, had it. Yeah. Pretty near every volleyball player I know has had it. Or some sort of GI thing. Yeah.
I was coughing.
Yeah. Well, Emily Johnson just got over it and it didn't hit her very hard. It was just a day and a half sort of thing for her. Some of her colleagues were very sick for a few days. I have another student who's missed several days of class and they're out of it. So, well, it's 7. So we'll go ahead and get started. And like I said, I didn't prepare anything. So it's up to you to ask questions. And if you folks on Zoom have any questions, feel free to unmute yourself and ask them. So that's what drives the discussion. When the questions run out, that's when I run out, essentially. So go ahead and ask somebody.
Did you already do the test questions, or are you going to make them like after the discussion?
The test questions that you guys did,
Well, I mean like the test in general. Like, have you already written that up yet?
I hope so. Saying that is tomorrow.
I didn't know if you were going to base any off of what we talked about tonight.
No, it's already written.
Okay.
Now printing it's another story because the printer's broken.
How many
Yeah.
of the questions did you use that we wrote?
Quite a few.
Okay.
I had to tweak them. Some of the questions were weird, not very well phrased, and then others had answers that were wrong. So I had to fix that. So. Yeah, it is really far back. I think maybe, so if we do this, and hopefully my machine, hopefully the wireless in here is stronger. So if I, okay, gang, say hi to your colleagues. So if we do this way, and I just pull up a chair.
How do you like the
I
iPad?
don't really have a blackboard back there.
I
But
think we'll get you in grad school. Yeah,
Mhm.
definitely.
Absolutely. Oh, yeah. Because like now I can keep track of all my notes and papers instead of like losing something. I feel way more organized too. You can just like download his.
All right.
notes. Okay. You asked your first question.
Could you like go over like the pathophysiology, for, like high blood pressure?
Of what?
High blood pressure.
Sure. What was that? Something blowing up a bucket or something? That was loud. All right, so when you have high blood pressure, the vessels, which are lined by endothelial cells, first of all, are subjected to shear forces that tends to increase inflammation within the vessels. Inflammation will cause the vessels to leak more than they normally do. The other thing that happens is that as the endothelial cells kind of stretch and do this, they're more likely to have LDL deposited under them, so it increases your risk of atherosclerosis. That's the second issue. When you look at the arterioles, because the arterioles are the main vessels that control blood pressure strategically, they get stretched and the smooth muscle surrounding the arterioles, in response to that, will start to divide. They start to divide, and they also, because they divide and there's more of them, they will start to narrow those arterioles. That leads to so-called essential hypertension. In this case, now you can't vasodilate. Your blood pressure is really always going to be high. In the brain, the small vessels will tend to have protein leak into the sides of the vessels, and you get this clear layer underneath the endothelium. That's called arteriolosclerosis. And those vessels are more leaky. They're also more fragile. They're more prone to undergo, to experience aneurysms and to explode and cause strokes. So high blood pressure has a lot of issues. The other issue where high blood pressure affects the bodies and the kidney, because high blood pressure causes the glomerulus in the kidney to thicken. And because it thickens, the exchange from fluid to the Bowman's capsule goes down at first, and then in exchange, the kidney starts to make more renin. And because fluid now will start to flow in the kidney, the thickened cells that are lined with lots of extracellular matrix now will start to just break open, and there'll be spaces in between them. And you get something called nephrotic syndrome, where essentially you get lots of protein and red cells and things just kind of going into the kidney, into the urine. And now the blood pressure becomes virtually impossible to regulate on its own. Also, you're losing lots of water and electrolytes and red cells, so you become anemic. And because it damages the kidney regulates red blood cell production in the bone marrow, that goes south too. Nephrotic syndromes are just bad. And so high blood pressure affects the arterioles, affects the blood vessels in the brain, affects the kidney in those three places. That's where you have your most acute effects. And then, of course, because of increased risk of atherosclerosis, your increased risk of heart attacks, and the heart can enlarge. You can start to have the heart can remodel in response to that. You can get pulmonary hypertension. Pulmonary hypertension, you'll start to get foam in the lungs. Yeah, it's bad. That's pathophysiology of hypertension in a nutshell. That's why, and when you have hypertension, you don't know it. There aren't any obvious symptoms. So that's why it's called the silent killer. So you need to take your blood pressure. Fortunately, there are good monitors now for blood pressure that you can buy in the store, and you can take them home. You can use them, and they're relatively accurate. So, yeah. Then you should keep a log. Go ahead.
Can you talk about baroreflexes?
Yeah. So the baroreceptors are stretch receptors, and they're in two strategic places in the aortic arch. The aorta is the vessel that undergoes the most stretch in your body, and in the carotid sinus, which is just where the carotid artery bifurcates into the internal, and external carotid arteries. So it's an inflation of the internal carotid artery. That vessel as well will tend to undergo stretch in response to whether or not you lie down or get up. So those stretch receptors detect essentially the effect of your body position on blood pressure. So if they're not being stretched, then gravity is probably pulling blood away from the brain. You're going to faint. So that baroreceptor essentially tells the brain the heart rate needs to go up. And that's why when you stand up, your heart rate goes up, because you have decreased stretch in the baroreceptors. Heart rate goes up, you undergo vasoconstriction peripherally. That allows more blood to be diverted to the brain, and the heart's pumping harder too to get blood up to the brain. That's a baroreceptor response essentially. And if you have so-called paroxysmal supraventricular tachycardia, there is a trick you can do called the carotid sinus massage that can lower the heart rate. EMTs were taught to do that. They're not taught to do that anymore, because several EMTs got a little too enthusiastic and damaged people's carotid arteries that way. But that's something emergency doctors can do to lower the heart rate sometimes. That's usually the result of someone who has had too much coffee to drink. You see that in people who drink too much alcohol and then they try to sober up by overdosing on the coffee. They get the paroxysmal supraventricular tachycardia. And then they'll pass out because the heart's beating so fast. And then when they go to the ED, the doctor will just massage their carotid sinus and the heart rate goes back to normal. So that's a baroreceptor response. So massaging essentially stretches it and makes the body think that you're fine. And that essentially takes away this activation of the sympathetic input to the heart. And therefore the parasympathetic input to the heart now predominates.
Can we review like some of the beta blockers and then like what is the worst and the best for maybe like pregnant women or?
Okay, yeah. So beta blockers as a group block beta adrenergic receptors. They're antagonists of those receptors. There are a few that are partial agonists. For the most part, they are antagonists. So acetobutolol and pindolol have intrinsic simple mimetic activity, ISA, because they're partial agonists of the beta receptor. Most of them are just straight up antagonists. There's two groups. One group is very specific for the beta 1 adrenergic receptor. The other group is not specific. It will inhibit both those receptors. And a good way to remember them is the first letter. If they're between A to M, they're selective. If they're from N to Z, they're non-selective. There are a few that are non-selective that are just used in the eye. They're just used as drops. So cartiolol is non-selective, but it's just available as drops. It's used for glaucoma. Timolol is non-selective. It's used mostly in the form of drops. There is an oral preparation of timolol, but it gets used the most for glaucoma. The selective ones, the one that gets used the most is atenolol, definitely. The other is metoprolol. Those can be used in people with asthma. Of the non-selective ones, propranolol is the one that gets used the most. It's used as a prophylactic for migraine headaches. It's used for anxiety. It's used for stage fright. Because propranolol is non-selective, you don't want to use it in people with asthma. It's also used in people with bipolar disorder who are taking lithium because it can treat the tremors that are caused by lithium. That's the other use for propranolol. So beta blockers are used for high blood pressure. They're also used for post-heart attack patients. They're used also in patients with heart failure. They're also used to treat angina. Certain types of arrhythmias are also treated very effectively by beta blockers, usually arrhythmias that originate in the atria and are tachycardic in nature. So they will be used for arrhythmias. They're so-called class 2 antiarrhythmics. The cardioselective ones will have fewer side effects than the non-cardioselective ones. You'd expect that, given that they bind to one less receptor. The biggest side effect is bradycardia and fatigue. That tends to go away after a couple of weeks. They do cause erectile dysfunction in males. The non-selective ones can affect sleep. They can give you funky nightmares in some cases. In diabetics, they can mask the tachycardia that accompanies hypoglycemia. So they have to be used with caution in diabetics. They can also raise blood lipids.
Is bradycardia and fatigue just like the main one for?
That's the main one that you see with all of them.
All of
Yeah.
them, okay.
The ones with ISI have less bradycardia and fatigue, but they still have some. So pindolol and acetabutalol. And then the two that also inhibit the alpha-1 receptor, that's carvedilol, which is used a lot in patients with heart failure, and labetalol. And labetalol is the one that's quite safe during pregnancy. It's also safe during breastfeeding. So say a woman is pregnant, her blood pressure's up, the doctor's afraid she might have preeclampsia. If he puts her on a drug like labetalol, she can stay on that drug while she's breastfeeding because it's still safe for breastfeeding. Methyl dopa tends to sedate the baby pretty substantially. So it's not recommended during breastfeeding. So that's one of the conveniences of labetalol during pregnancy. Because if you have preeclampsia, your blood pressure tends to stay high for a couple of weeks, then it just tanks, just all of a sudden. And then your blood pressure gets too low and you have to get off the drugs.
Can you talk about what renin is and what it does?
Yeah, so renin is an enzyme. It's made by the kidney. The nephron has a portion of it called the distal convoluted tubules that ascends and passes the Bowman's capsule. As it ascends, it goes between the afferent efferent vessels that feed the glomerulus, feed and drain the glomerulus. And the tissue that connects the DCT with the glomerulus, that menagerie of cells plus the cells of the DCT that go from being cuboidal to higher to more columnar. That's called the juxtaglomerular apparatus, and it monitors blood flow into the nephrons. If blood flow decreases, then the juxtaglomerular apparatus detects that and secretes the enzyme renin into the bloodstream. Renin is a peptidase. Its main substrate is angiotensinogen, which is a beta globulin made by the liver. And it clips angiotensin into a small peptide. The rest of the protein, the C terminus of the protein, has no function as far as we know. It's degraded, and the amino acids are recycled. But the front part of it, that little peptide, is called angiotensin 1. That really doesn't have any biological function either, as far as we can tell. There was an early report that it caused a little bit of vasoconstriction. That report is widely disbelieved today because the result wasn't repeatable. But angiotensin 1 circulates through capillary beds, in particular in the lungs. And the capillary endothelial cells in the lungs have angiotensin converting enzyme that clips a couple amino acids off the back end of angiotensin 1 to make angiotensin 2. Angiotensin 2 is a very short peptide, but it has extremely potent physiological effects. It's a systemic vasoconstrictor because it binds to the AT2 receptors found on the surfaces of endothelial cells, surface of smooth muscle cells that surround blood vessels, causing them to constrict. And it also signals to the cells of the adrenal cortex, to secrete aldosterone. So aldosterone causes the kidney to retain sodium in exchange for potassium. So now sodium levels go up in the blood, therefore you have more water in the blood. So greater blood volume, greater blood solutes, and vasoconstriction. So angiotensin 2, which is made, renin doesn't make it, but it gets the ball rolling in making it. substantially raises blood pressure. That's why it's a nice target for treating blood pressure. So aliskiren is a renin inhibitor, a direct renin inhibitor. Because that drug is new and expensive and has more side effects than either ACE inhibitors or ARBs, it's not prescribed that much. The ACE inhibitors inhibit angiotensin converting enzyme, and then the angiotensin 2 receptor blockers antagonize the angiotensin 2 type 1 receptors that cause vasoconstriction, thereby lowering blood pressure. Angiotensin converting enzyme also degrades a peptide called bradykinin. Bradykinin is made from a larger precursor called kininogen. Kininogen is just made by endothelial cells, but it's converted to bradykinin, and bradykinin causes vasodilation. It prevents clotting, but it can also increase inflammation. So angiotensin converting enzyme keeps bradykinin levels low. But when you inhibit angiotensin converting enzyme, bradykinin levels also increase. That increases your vasodilation even more. In some people, you can vasodilate too much, and your vessels around your neck and face will start to leak, and you have a transfer of fluid from vessels to peripheral tissues, and that's what causes angioedema, which is the serious but rare side effect of ACE inhibitors and angiotensin 2 receptor blockers. ACE inhibitors are more likely to cause angioedema than ARBs. And of the ACE inhibitors, they all seem to work about the same. The differences really are in half-lives and things like that. Captopril, for example, has a shorter half-life than some of the others. The others you can just take once a day, which is more convenient. Out of the sartans, telmisartan is supposed to be the strongest. That's at least what happens in the laboratory. Clinically, they all seem to be about the same. The other side effect with ACE inhibitors is an annoying cough. And then both of those drugs will increase potassium levels. But if you hydrate, that's usually not so much of a problem. That help?
Yes, thank you.
So for any antihypertensives, like on the PowerPoints, it talks about the adverse effects and precautions, so that we should all know that stuff for
Yeah.
the exams.
Yeah. Drug interactions are important. And the thing is, PTs and OTs and nurses, it turns out people are not likely to tell doctors everything they're on. They're more likely to tell the PT or the OT. Part of it is and the chiropractor, because you touch your patient. That changes the relationship between you and the patient. With the doctor, okay, the doctor touches them, but they kind of allow it. Whereas touching the patient is part of your job. You have to touch them. That changes the relationship. They're just prone to trust you more. So PTs, OTs, and nurses are more likely to detect drug interactions. And in fact, correct me if I'm wrong, before you treat somebody, you have to have a list of all the drugs they're on legally.
Mm-hmm.
For PTs, you do. I'm pretty sure for OTs, you do too. And usually what you do is just say, throw your drugs in a Ziploc bag and bring them to me. And I'll just fill out a list, or my assistant will fill out a list of all the drugs you're on. And sometimes you'll see stuff that the vet prescribed their dog that they take. I mean, I've heard stories, things that you would not believe. Ketamine, because ketamine is prescribed to animals. Some people take ketamine because it makes them feel better. They're in pain. It takes away the pain. And then they get hooked on ketamine because they get it for their dog or something like that. It's just kind of wild. So herbal remedies too. They'll tell you about the herbal remedies, won't tell the doctor. Oh, the doctor doesn't care about that. Well, you will say, do you take any herbal things? Just anything, even occasionally. Oh, I have some St. John's wort, helps my mood. Oh dear. St. John wort, is a powerful inducer of P453A4. So that means these drugs, their half-lives are tanking. Oh, that drug never works for me. Well, because you're drinking St. John's wort while taking that drug. So the drug-drug interactions, it's going to be an important part of your job. So learn those. Learn those. I know they're pain, but fortunately there are programs you'll have that will identify interactions. But there's some that you'll just know because you see them all the time. So, erythromycin or azoles or drugs like that. Yeah. Remember, calcium channel blockers are also quite safe during pregnancy. That's the one group that's pretty safe during pregnancy. So if someone has high blood pressure, you can give them a DHP, a dihydropyridine. Those are safe. That methyldopa-labetalol, those, and in your notes, you have a table of the drugs that are safe in pregnancy and breastfeeding. I forget what page number it is, but it's in there somewhere.
We should probably look that over tonight too.
You should probably look that over tonight, yes. Yeah.
Got a lot to do.
Well, should we know like the PQRS T waves? No, like the
ECG.
You should-
yes.
EKG.
EKG, yes.
Right. You should know what an EKG looks like. Yeah. You should be able to say there's a P, QRS, T wave. And if you're missing one of those, or if one of those looks really funny, something's not right. Now, this is not an EKG class. I won't ask you what's wrong with this EKG. That kind of goes beyond the scope of this class. But if I tell you Henry comes in to see his doctor and his heart rate is 120, you should know that's too high. If Melissa goes to her OB and her heart rate's 40, you should get worried.
Yeah.
That's too low. So you should know the range. And you should know if someone says, I can feel my heartbeat, that's palpitations. No, you shouldn't feel that. Okay, after you've run a marathon or something, okay, fine, you'll feel your heart rate, that's fine. But if you, in the park home run, you get to home plate, yeah, you're gonna feel your heart rate, your heartbeat, but not when you're resting.
What if you feel that like before a quiz? I just felt that today.
That's anxiety,
Oh, okay. I know that. Okay.
yeah, yeah,
Cool.
no. It happens to me when I go see my doctor.
Really?
The nurse just walks in the room and my heart rate goes crazy. It's ridiculous. It's just ridiculous. And these are people I know and like, and still when they walk in the room,
Is it
just
like
go, it's
a white
horrible.
coat or?
Yeah.
Yeah.
I just don't. Once I'm there for a while, I'm fine, but dang, I saw my dermatologist several months ago. The med tech walked in and I could just feel it. I'm like, stop. It just, that's the way I am. So they know, they take the first blood pressure and they completely ignore it because they know it's going to be high because I'm all tanked up. I'm all jacked up, just the way I am. So, oh well, welcome to me. Procedures. If I have a procedure, I get really nervous before procedures. Any procedure. Because I'm at the age where I have to have colonoscopies every 5 years. And I know I'm going to be asleep for the whole thing. I'm not going to remember a bit of it. But still, when they come in to do the vitals and everything, I just feel it.
It was the same way for my surgery. They did get my blood pressure 3 times because it was so jacked up. I was so nervous.
So propofol, fortunately, does a lot of vasodilations. That brings it down. So that's the anesthesiologist said, do you want some midazolam? It's going to make me drunk. I don't want to be drunk after. No midazolam. Hold the midazolam, please. That's the drug that goes by the trade name Versed. That drug, literally, when you wake up, you're drunk. You can't walk straight, you can't talk, you can't see. It's horrible. You're just,
And some of the HDL is gonna be on here, right? This exam or the
Uh,
LDL.
lipoprotein
Yeah.
particles, you should know what,
Yeah,
what,
okay.
how they're made, what they're for, what the body uses them for, which ones are good and which ones are bad and why.
Yeah.
Um,
Can you talk about statins?
that mean cholesterol handling,
Yes.
sure. So cholesterol is made, every cell in your body can make cholesterol, but the main organ where cholesterol is made is the liver. And you also get cholesterol from your diet, particularly if you eat animal-based products. If it grows on the ground, it doesn't have cholesterol. Full stop. So cholesterol from the diet with fat is taken up by the enterocytes of the small intestine. Fatty acids are actually remade back into triglycerides. So the triglycerides get broken down. Fatty acids and the glycerol are taken up and then they're remade. And then the cholesterol, the triglycerides are made into a chylomicron. They're then delivered into the lymphatics. From the lymphatics, they will sojourn through the lymphatics and then to the bloodstream through the thoracic duct. They encounter lipoprotein lipase. They are gradually depleted of fat until they become a chylomicron remnant. One of the apolipoproteins they have is ApoE. ApoE allows them to be taken up by the liver very effectively and very quickly. So chylomicrons normally don't tend to cause atherosclerosis in most people. Once taken up by the liver will take the cholesterol and fat and use it to assemble a VLDL, very low density lipoprotein particle. So cholesterol and fat in a VLDL comes either from the fat and cholesterol made by the liver or fat and cholesterol that came from the diet. They are excreted by the hepatocytes. Remember, the hepatocytes line the hepatic sinuses. So they excrete it into the blood in the sinuses. The sinus blood, remember, mixes with the hepatic vein, portal vein that drains the blood into the inferior vena cava. So that goes straight into the circulation. It will deliver fat and cholesterol to peripheral tissues. Some tissues use some cholesterol, some use a lot of cholesterol. Ovaries, for example, are cholesterol pigs. They take up a lot of cholesterol because they're making steroid hormones and because the uterus, because of the monthly bleeding cycle, cholesterol is really necessary for repair, cell repair. In fact, if you get an injury, that healing tissue will be a cholesterol pig because healing tissues will usually need a lot of cholesterol too, and a lot of fat too, for that matter. Any VLDL that's not used can be taken up by the liver, but the VLDL, as it sojourns through the body, will start to lose surface apolipoproteins, and it can be converted first into an IDL. An IDL still has the ApoE, apolipoprotein, but it starts to lose proteins that cause it to be depleted of fat. So its depletion of fat is slow. When it is completely depleted of fat and it loses ApoE, it now becomes an LDL particle. So if I ask you on a test, is LDL made by the liver? The answer is no. An LDL is made from an IDL. An IDL is made from a VLDL. The liver makes a VLDL. It doesn't make an IDL or an LDL. The LDL particle, because the uptake by the liver is slow and highly regulated, its residence time in the body is long. Can be a few hours, can be a few days. Some cases can be even up to a week. So that's why if your endothelial cells start to stretch and are no longer attached properly to the extracellular matrix that they sit on because of high blood pressure or turbulence or damage or something like that, they will dive underneath and stick to the extracellular matrix underneath the endothelial cells, and their LDL will be oxidized. And the oxidized LDL will A, induce the endothelial cell to make lots of cell adhesion molecules for white blood cells, and the endothelial cells will make cytokines that summon white blood cells, in particular macrophages. So the macrophage will adhere to the endothelial cell. It'll then flatten and move in between it, and it will gobble up the oxidized LDL. If there's too much LDL there, the macrophage will give up the ghost and become a foam cell. The foam cell and its the demise of the macrophage, well, while the macrophage is dying, it will start to send out molecules. It'll not only make growth factors, but it'll induce the endothelial cells to also make growth factors. It makes several growth factors, but one of them is platelet-derived growth factor. That's one of the biggies that induces a smooth muscle to proliferate and migrate and move around the foam cell lesion. When the smooth muscle cells have not surrounded the lesion, it's called the fatty streak. Once the muscle cells surround it and form a cavity, it's now called an atheroma, sometimes also called a plaque. That starts to occlude the vessel. Inside the foam cell, metal metalloproteases can be elaborated. They can start to erode the cap. Sometimes it erodes the cap a little bit, and then the cap is stable and it's much ado about nothing. But if you're in an area of high turbulence, you can get lots of erosion, both from the shear forces of the turbulence and from inside, and the cap will burst. And then the atheroma that's exposed can do one of two things. You can have a fat bolus that moves through the blood vessels, and it can plug little capillaries. You'll get a little rash called levodo reticularis. People get that sometimes after stents are put in. They get this rash on their arms. That's called levodo reticularis. That's little bitty cholesterol blobs that are blocking little vessels. But that area now is extremely thrombogenic, and platelets stick and they make clots, and that clot fills up and it will block the vessel. And now you have an infarction. And if that clot breaks off, it's not a thrombus anymore. Now it's an embolus. An emboli can get stuck in places and cause myocardial infarctions if they get stuck in coronary arteries. They can cause strokes if they get stuck in cerebral arteries. They can cause deep vein thrombosis if they get stuck in veins of the legs. They can cause all kinds of trouble. So, all right, and then the HDL particle is made by the liver and by the cells of the small intestine. So it begins as an immature little disc-like structure that just has apolipoproteins that clump together with fat and cholesterol. You get this kind of UFO looking thing. As it starts to take up more cholesterol, it becomes spherical. And these will remove excess cholesterol from the surface of cells. It can also remove excess cholesterol from plaques that have not been sealed off. That's why they're protective against atherosclerosis. They then deliver that excess cholesterol to the liver, where they're immediately dumped into the production of bile salts. That's called reverse cholesterol transport. That's why HDL is the protective particle against atherosclerosis, whereas LDL is the pro-atherosclerosis particle. That's why LDL is called it hurts me to say it, bad cholesterol. And HDL is it pains me to say it, good cholesterol. Sounds like you're scolding cholesterol. Bad cholesterol. You go sit in the corner. Yeah, right. But again, it has educational usefulness. So, okay, I'll go with it, even though it's bad lithium. Lithium, you're so bad. You have an extra electron. Confess. Yeah, right. Lithium doesn't care.
This doesn't have to do with pharmacology, but like for OT, it's like if you're working with a stroke like victim, would that mostly be due to like the clog in the
Yeah, or it might be due to an aneurysm, or it might be due to other stuff. If they have atrial fibrillation, they're at higher risk for strokes because with atrial fibrillation, blood pools in the arteries, and you can get thrombi that form and then they break off. And if they form on the left side, one of the places they tend to go is the brain. That's why people with atrial fibrillation are always on antiplatelet drugs. Yeah. Sometimes strokes form just because people have blood vessels that have just been kicked around and they get clots that form on them. And they just travel the place they happen to lodge is in the brain. So it just happens. Yeah, it's very sad. But the brain's ability to repair itself is much bigger than anyone ever thought. There's a book you'd probably be really interested called How the Brain Heals Itself. I can't remember the author's name now, but it's fascinating stories. A guy who actually works with brain rehab, neuro rehab, and things he's been able to do to get people to come back from seemingly impossible situations. That's well worth a read. Once the summer hits and you have time to read, you should definitely read that book. You'd enjoy it, I think. Plus the stories, I think some of the stories in there will just make your heart a little bit lighter and will make you really love, this profession that you've chosen. So, yeah.
Yeah.
Katie, you're
I
good?
just need to
Okay.
study more.
These guys are all out of questions. You guys have any more questions?
Could you just go over some of the drugs for cholesterol really quick, like niacin and ezetimibe?
Yeah, I can, but remember I said those drugs would not be on the test
Oh, okay. I did not remember that. Never mind.
because
Thank you.
I thought it was just too much to have that other set of slides on the test. Because the cardiac stuff, the antihypertensives, cholesterol handling, and then the drugs too, I just thought it was too much. Is that fair?
Yes, thank you.
Okay, so those drugs won't be on the test. They will be on the next one though. So you need to learn them eventually, just not now. So that'd be statins, fibrates, bile acid resins, niacin, and then the monoclonal antibodies we talked about. And then there was a new drug that was just approved by the FDA 2 weeks ago. It's a miniature RNA that has a group attached to it that gets it into cells. It takes the messenger RNA for PCSK9, and degrades it. It's so cool. It's so cool. It's new, it's really new, but it seems to be extremely well tolerated. Extremely well tolerated and small. So the injection of antibodies, when you inject them, they can just cause more irritation. This thing, because of the fluid you're introducing, you get injection site reactions and you get some fatigue and some joint pain, but it's transient. It seems like it's really, so for people with familial hypercholesterolemia, that this might be the new wave of medications. I just think that is so cool. Just a really ingenious medication. So Anything else, gang? They're thinking, they're thinking, they're thinking.
I don't have anything else.
Okay, Bree, how about you?
I'm good.
By the way, that picture of you with, was that your cat?
Yes, my profile picture. One of my online
Yeah,
classes, we had to
that's a
add.
cute kitty.
She is.
I mean, I like dogs, but I like cats too. So I just, the first time I saw it, I said, oh, kitty. Okay, I'm gonna go home and soak my head. Okay, guys, study hard, make me proud. See you tomorrow. Signing off. Bye.